Hey, how are you? Welcome back to another episode of Covering Your Health with Evelyn Erives, presented by IEHP. So happy to have you here again for another exciting episode. Really, this is a fun one. And actually, it's a couple of fun ones today. If you are like me and chronically online, yeah, I'm guilty. We were guilty. I'm online all the time. You probably have come across a bounty of memes, right? One's about food, one's about work, life, that word aging. For example, if you had a New Kids on the Block sleeping bag, you might need to ask your primary care physician about menopause. I felt personally attacked by that one. I just want to say, it makes me feel a little old, but you know what? That's what funny stuff online is all about. The funny part about it is we should be talking about it more. We should be talking about topics like that. And that is what covering your health is all about. And we love the idea of aging gracefully, whether or not you had a New Kids on the Block sleeping bag or not. With that, I'm so excited about today's episode. We want to be able to provide you with the ABCs of topics that will really help. And today, the topic of aging is one of them. If you hadn't guessed it, we're going to deep dive into these words: perimenopause and menopause, what the symptoms are, what to look for, what to talk to your doctor about, and how you can keep your family informed about the ups and sometimes the downs of life experiences. And we have the absolute most perfect guest to help answer my and your questions. I wanted to say burning questions, but then I felt like that might trigger someone's heat flash. Okay, enough joking around. Today's episode is one of two episodes on this particular topic. We're going to welcome Dr. Samar Nahas, a physician with UCR Health, the clinical enterprise of UC Riverside School of Medicine, specializing in gynecologic oncology and minimally invasive surgery. Dr. Nahas is one of three GYN oncology surgeons at UCR Health, focused on the care of women's health needs from chronic pelvic pain to menopause. And she'll be our tour guide, so to speak, and she's a great one of sorts to navigate through this fiery topic together. Cannot wait to get started.
Welcome to Covering Your Health, a wellness podcast dedicated to covering all areas of living a healthy and happy lifestyle. From healthy hearts to understanding health plans and everything in between, each episode will provide you with a better understanding of managing your health, preventative care, and staying on the right path for your family's wellness journey. The Covering Your Health podcast is presented by IEHP. Now, your host, Evelyn Erives.
I am so excited to have you here, Dr. Nahas. Thank you so much for being here.
Oh, thank you for inviting me. This is so exciting. I love any forum of education to educate our patients, our friends, our population. So thank you.
This is great. Well, let me start by first getting to know a little bit about you. Every episode, when I have a new guest, I like to get to know them a little bit better. So, Dr. Nahas, tell me, what got you into this line of work? Were you always passionate about this type of medicine? Tell me.
Um, it's I'll tell you a little story. So it tells for future episodes. We don't have to repeat it, but this is important for if the audience are interested. I grew up in the Middle East. My parents, none of my family was in medicine, but from when as long as I was as I had memory, or when my mom tells me story, I knew I wanted to be a doctor. How, why? Because there was no influence in the family, no influence from my parents. So I think it's just, some people are born with specific passion.
Mhm.
As I grew up older and older, I loved art and beauty. So I always imagined to be a plastic surgeon or something that is more crafty in medicine.
Yeah.
So
Yeah.
some sort of a surgeon. Not really women's health, and I don't know why, but I was more into I want surgery. I want to do something with my hand, and I didn't have a lot of knowledge growing up. I didn't have a lot of education into what does it entitle? What does this line of work mean? What does that other line of work, or this field and that field, this specialty, that specialty? We know them. If I'm a patient going to the pediatrician, this is all my experience and exposure. And internet when I was born, not long ago, but longer probably than you and our younger generation, we didn't have a lot of like information available to us. If you wanted to know something, you had to go to the library, find a book, and that was not an easy process. So that was my understanding or knowledge is just by visiting a specific doctor if me or my family member had an issue. So it was limited exposure. Then definitely knew I wanted to be a surgeon. It was a very, very difficult journey. Not easy. It was like I'll give you an example. If an 80 million population where I grew up, only 200 female back then will be selected that year to enter medicine. No private
Wow.
schools, no other options. So it was very limited. So I had to be very driven. I had to
Yeah.
really had a passion to what I do. Fast forward, entered medicine, got lucky, and then through the first, it's like the British system, we had to do it 7 years. So it's longer education. It's out of high school, so, which was better for me because I had more in-depth education about medicine. And then toward the fourth, fifth years, we do clinical rotations. I'm still in my head. I want to be plastic surgeon or a surgeon.
Yes.
Um, Fast forward, I did not really get into being a plastic surgeon because the field was not there. There was no residency where I grew up.
Oh.
So someone advised me, well, enter OBGYN and then you can change. Then you can go another city or travel or, somewhere else.
Mm-hmm.
So I did not really like it, didn't like the idea because there was a stigma that, oh, if you're a woman, only you have to go to a woman doctor, which is a
Right.
gynecologist. And
Right.
growing up in Saudi Arabia, I hated the fact that I'm restricted by being a woman. I did not want anything to restrict me any further. So I did not want the field that was better for me because I'm a woman. So that was
Yeah.
probably what was in my mind of rejecting it, rejecting the idea altogether. Because also I lacked the knowledge of how amazing and beautiful the field is. Because if I love my family, if I love my mom, if I love my daughter, this is one of the best gifts I can give to them when
It
I get that
is.
knowledge. So I entered it. It was a little adjustment, but then I got exposed. The first year of residency was 5 years of residency into, oh my gosh, they have different subspecialties. It's not all general OBGYN as I thought it is.
Yeah.
From my limited experience as a patient, they have infertility subspecialty, they have high risk pregnancy, they have a family medicine, they have gynae oncology, which is pure surgery. So I'm like, oh my gosh, so I don't really have to do OB or deliveries if I want. I can still be the advanced surgeon I wanted to be. And then my mom got breast cancer. Then we
Mm.
discovered that we had the BRCA gene mutation, BRCA.
Oh.
Long story, long battle with cancer. And that really brought me closer to the oncology side of practice and being a cancer surgeon. Not because only I love surgery, but oh my gosh, I'm actually doing something amazing. Everyone does something amazing. All the fields are amazing, but it
Yeah.
was closer to my heart since
Yeah.
my mom had cancer, had to go through surgery, radiation, chemotherapy. I felt like I went through a life experience that I learned from a lot of doctors what to do and from most what not to do.
Wow.
A lot of surgeons, when they came and saw my mom, they treated her as a customer, as the next. And I was with her through the whole journey. The hospital, I put a hold on my studying. It was
Yeah.
2 years of her battling toward the end. And then that brought me closer and closer that, okay, I'm going to help patients like my mom, and I'm not going to be like those doctors. I
Right.
will be like one of those, the few of them that really, really, even if they really didn't cure her or didn't really offer it a lot, but just the way they talked to her, the way they looked at her, the way they looked at me, I was like, I want to be a healer. That's considered a healer. So I always tell my students now, I'm like, you're not only a doctor, you're not a specialist of a certain part of the body. When you go see your patients first, you have to drop that she's the next customer. You put in your mind that I'm going to see my next, my mom, my daughter, my cousin. So how do you like to talk to them? How do you like to break the knowledge for them or the good
Yeah.
news or the bad news? How would you like to sit and eye level talk to them, and be emotional a little bit, be warm a little bit, obviously
Yes.
within the limit. So I felt that I'm doing a lot more than I ever dreamt of doing, and I'm blessed doing this every day. Like it just makes me so happy, makes me so satisfied, makes my patient happy because they feel there's a difference. And got lucky, got into the gynae oncology field. So now I did double fellowship training. I did gynae oncology, and I did another minimally invasive fellowship at Mayo Clinic. And that's to do the same surgeries I do with smaller incisions, so
Yeah.
that it helps the patient get the same outcome, but faster healing, faster recovery. So they don't have to suffer. No one needs to suffer if they don't have to. So sorry for the long introduction, but I think it's important because not a lot of people talk about how important for a physician um, to be a healer. So to
Yeah.
focus
Yeah.
on the, I'm not a psychiatric and I will never be, but to also focus on the patient's mental health and physical health, I call it the
Hmm.
balance. So yeah.
I love that. No, I love how passionate you are.
Thank you.
I even love like what I think specifically taking away from that is that you really saw yourself on one path. You saw
Yeah,
yourself doing something completely different. And then you found your through the way it worked for you, you found your real lust for life
yeah,
in this profession.
yeah,
That's very cool. That's
yeah.
really inspiring
Thank you.
too.
Thank you so much. It's just a different connection. And I try
Yeah.
to teach that to my, they don't teach it enough. They don't teach it at all, actually. So I try in my limited experience, give that to my students, give that to my
Yeah.
fellows, so they can also take it over into teaching that to the next generation.
I
Yeah.
love that.
Thank you,
Well,
Evelyn.
let's dive in to
Yes.
this whole perimenopause,
Yeah.
menopause. We've heard basically those terms our entire lives,
Yes.
right? Like that's just what, okay, perimenopause, menopause. So can you tell us what is the difference? What is it? What is perimenopause and what is menopause? And when does that happen? Like, is there a time bomb that's going about to go off?
So menarche is when the patient in their puberty they have the first period, and then that's different between age 9. There's also premature, there's normal age, there's late, but a variety of different physical body, different hormone, genetics,
Yeah.
sometime, and then same with menopause. So the whole period, when we have a period, I consider all that as perimenopause. But because there's no actually real definition or timeline of a you are premenopausal, no, there is no such a thing.
Yeah.
But most
Okay.
people call, so any time before menopause is premenopausal to me. But most physicians and patients will put that term specifically toward the end before menopause, so the last 2 3 years of the changes that happens to our body that makes us premenopausal. But there's no such a thing in my opinion.
Okay,
uh,
good.
and not everyone is the same. It goes with family history significantly, because if there are more families are they don't really feel anything, and all of a sudden they don't have a period. Oh, okay, I don't have a period. They don't feel it before, they don't feel it after. So it
Right.
really varies. So there's no condition or a disease or a syndrome that makes you suffer more. It's just it
Yeah.
goes. I always ask family history because it's very typical that you see the same thing repeat itself with the mom side of the history, right? So, but unfortunately, some patients will start having the path between the pituitary gland and the ovary kind of get dysregulated, because if you have a regular period and if your whole life everything is good,
Hmm.
then you have the monthly cyclical changes and signal between the pituitary gland to the ovary, you ovulate, and then the balance between estrogen, progesterone, and it's all to actually make the uterus ready for us to carry a baby. So it's our
Right.
natural physiology for us to be fertile and to give birth and to make this beautiful life going, right? And
Hmm.
then toward the end, most patients will not have any significant change in their pathway or the balance, but some will start having that pathway interrupted, I'll say, for no reason that we know to our knowledge. most likely, if they suffered from irregular period and stuff, they might be suffering more toward the end. Some
Mm.
conditions like, again, family history, obesity, external estrogen, external influence, the food we're eating now, the air we're breathing. That's a lot of environmental factors also that is not well studied, not well known, because it's a lot of variables. How could you monitor that, and how could you
Yeah.
study that, right?
Yeah.
So a lot of factors that could lead to that, but we cannot pinpoint, oh, you're going to have a high risk or you're not going to have a high risk. But if the patient come and saw us, and most patients will go through that seamlessly without really seeing a physician, but some will start having that path interrupted, and then that will lead to irregular ovulation. So then the balance between estrogen and progesterone that should happen on a monthly basis, because if you
Yes.
ovulate regularly, the balance is perfect. If you don't ovulate, then you have imbalance between estrogen and progesterone, and then you might have irregular period, and or heavy period,
Right.
or little period. So most patients, the little, if the oligomenorrhea or less amount of monthly period won't
Yes.
bother them. Irregular toward the end will also not bother them a lot. It causes infertility early on, but toward the end, if I miss a period, well, I won't, personally,
Yeah.
right?
Yeah. Right. I'm
But
like okay
then,
with that.
right. But the patients that will show to our clinic is when they start having heavy bleeding. And
Yes.
sometimes that imbalance causes real, we call it abnormal uterine bleeding. They call it menorrhagia. There are a lot of terminology, but it's the excessive bleeding that either lasting more than 7 days, or excessive bleeding that is resulting in a passage of clots, because clots are not normal. No woman should have clots with their period. So anytime you have clots with your period, that it's one of the indications that you're having menorrhagia or abnormal uterine bleeding. So
Hmm.
then they have to obviously not only for that specific condition to affect their quality of life, because then they're embarrassed, they're bleeding through, or they're symptomatic, they're bleeding too much to the point that they're anemic. And
Yes.
some patients go even to the emergency department needing blood transfusion. So
Hmm.
it's more rare, but it's also one of the pictures that this could present with. So they come to us. The first thing we want to rule out, if the patient having a high risk of genetic mutation or endometrial cancer, is we want to rule out endometrial cancer, because
Yeah.
it's one of the most common cancers that we get. So according to American, we take a lot of our management planning and guideline from evidence-based medicine, from
Yes.
American College of OBGYN. They have a lot of guideline. One of the guideline that we have in abnormal uterine bleeding is the need to biopsy or we call it endometrial biopsy
Yes.
if you have high risk, obviously for endometrial cancer, obesity, known genetic mutation like BRCA or Lynch, or if you have just family history that but you're not known genetic mutation. But even if you don't have any of that and you have abnormal uterine bleeding and you're older than age 45, then we should do a biopsy just to rule out endometrial cancer. Why is that? Because anytime you have the imbalance between estrogen and progesterone, that could lead to mutation and atypical cells in the uterus. And as we go older, our body is prone to have more mutations. So we just want to rule out that before
Hmm.
we
The safe
plan
side.
management.
Right.
Exactly.
Just be on the safe side.
Right. So that's when, and then if everything is okay, then we give the patient some, most of them will be lacking progesterone because they
Hmm.
have more, if they don't ovulate regularly, they have more estrogen than progesterone. So either put them on some oral contraceptives to regulate their hormones,
Yeah.
or put an IUD in, or give them just some progesterone. And we can cover that in another topic. What's the difference and side effects and stuff like that.
Yeah.
Uh, what's menopause? Menopause is a distinct definition. A lot of people will go, there is a big myth or misunderstanding, even from our OBGYN community,
Hmm.
because they'll do hormonal testing, they'll do FSH, LH, estrogen, progesterone. The only definition in our textbook is menopause is no period for 12 months.
That's it.
Simple. That's it.
That's the definition.
That's the definition. And why do
That's
I not go
interesting.
bother? Exactly. Why do I not bother by doing hormonal testing? And a lot of people go crazy about that. Um, not because everyone is doing it is the right thing. Why is that? It's a burden on the patient, it's a burden on the
Yeah.
healthcare system. But also, we know if you're having issues that you have imbalance in those hormones. So I'm gonna test you, do the blood test this month, and I get some results. I'll do it another month, and you're actually fluctuating. I'll get another
Right.
result. So what's the point scaring you for no good reason or telling you a result that okay, what is it? I'm going to end up treating you the same thing, ruling out cancer and giving you some hormone if you're suffering, right? But
Yeah.
then the real definition is 12 months of no period. So that's it.
Wow. Oh my God. I feel like I just learned a whole lot right now about myself for the
Oh,
record.
yes, good. That's good. I'm happy.
No, that is so fascinating to me because you always okay, well, the perimenopause, I loved the way you explained that because you're right, like we're all basically in it, right? Like we're all in it
Yeah.
for our whole lives
Yeah.
basically. And then all of it
It's
then it's like,
it's
yeah,
pre-menopause. So
pre and
anything
then
before menopause.
everything before your period stops for 12 months and that's
Yeah.
it.
Yeah, exactly. Exactly.
That is fascinating to me. Well, I not to bring my own life into this too much, but I could relate to a lot of what you were talking about because I had very irregular cycles in my late well, like my mid 30s.
Yeah.
And it was leading to terrible things.
Yeah.
I
Yeah.
felt like
Yeah.
my body was falling apart on me and I could not understand. But I also listened to my mother, and my
Yeah.
mother,
Yeah.
who had to have a hysterectomy at very young age, at
Yeah.
29 years old.
Oh my gosh. Yeah.
So I made it to 36 years old.
Oh
And then
wow.
I had to have a hysterectomy because it was
Yeah.
partial. I still have my
Yeah.
ovaries, but
Yeah.
I was getting the blood clots. I was
Yeah.
having all of the really irregular 2 week long cycles, not 7 days.
Yeah.
It was, and it started scaring me. I passed out. It was like
Yeah.
that's when you have to go to the doctor.
Yeah. When my
So
patients come and talk to me, I say, first, obviously symptoms, because
yeah,
if you're bleeding to the point that you're anemic and needing blood transfusion, you're a zombie. You
yeah,
are weak. You can't do anything. You can't enjoy your life, your
yes,
family. What's the point of something that you can simply treat, right? Why are you suffering? But also, even if she doesn't have any of those symptoms, she's good. She's eating good. Her hemoglobin is good. Is it affecting her quality of life? What
yes,
if it is a
yes,
yes? No, don't just then seek treatment. There's like anything else in life. We treat, then you improve, then you go and do great things in your life, and not
yeah.
and get that away
I
from
just have to tell you, well, it was life changing for me.
yeah,
I
amazing, amazing,
I
amazing.
literally went from misery to feeling 1,000 times better,
Yes.
like energy's back, all of these things. And honestly, but that's also kind of like the question is I don't know when
Yeah.
I will be in menopause because I don't have a period.
Well, you might be one of those that are blessed and not feel it, right? So
Right.
we all advise, according to evidence-based medicine, the limit we have is after age 30, we have to be on our calcium, vitamin D, multivitamin, weight-bearing exercise. So that's essential, right?
Yeah.
After 30, doesn't even have to do anything with menopause. It's essential for our
For our
longevity and,
bodies.
and our health in general. And not only longevity, the healthy longevity. I don't want to be a 70 years old that is broken 100 times and bedridden in the hospital. I want to be
Right.
the 70 years old that can still hike and can still travel. So that's all bone density. That's all heart, like your
Yeah.
mental health, your cardiovascular health. So
Hmm.
all those important essentials that you need to start early on with the regular exercising, the healthy food, not to the extreme, but it has to happen early in life, and you have to be very aware of it. You have to teach
Right.
it to your students, to your kids, to your family. So that's very important. But it becomes even more important when you are closer to menopause or menopausal, because estrogen and progesterone, they do have those elements of helping with the bones. After
Yeah.
that, we don't have that help. But it doesn't mean that we are deprived. We still, if we're doing all those healthy supplements and exercise, we will live healthy as long as we can, and we don't even need hormonal therapy. If
Yeah.
we're one of those lucky ones, the family, like you will say your mom, exactly. If you go ask her, did you feel anything when you're like going from age 45 to 55 or something? She'll say no. Sometimes she'll say, yeah, at some period I was like sweating a lot, but then it went away.
Yeah.
Perfect. That's menopause, right?
Yeah.
But you don't. Not a lot of people know, especially if you don't have a uterus, will suffer from menopause. Most
Yeah.
people actually won't. Unfortunately, there are people that suffer tremendously from menopause.
Yes. Yes.
Mental health issues, very emotional, especially with someone that is have subclinical issues with mental health,
Oh.
and also like uh vasomotor as well, like the hot sweat, the sweating, the
Yes.
hot
Yes.
flashes. I don't know how to explain it. Maybe after I get to menopause I'll understand, because a lot of things, even as a physician, it's so
Until
different when
you
I
live
read it
it.
in a book until you live it. I hope I don't live it, but you know what I mean. But when I see my
No one
patients,
wants
some
to
of
live
them
that.
are like suffering.
Yes.
And
Oh.
sometimes also they also lead into sexual dysfunction, like
Oh.
dryness. So it
Hmm.
does affect also their quality of life. No one wants
Right.
to, because of silly reasons, affect their quality of life. Everyone wants to live to the full spectrum of the how can they live
Yes.
happy, right? So
Yes.
at any point, if you're suffering from all of it, so whether it's the motor symptoms, the hot flashes, the can't sleep, insomnia,
Oh.
the emotional, you're talking to someone, you're breaking in tears, you're depressed, especially if you're subclinically depressed and not diagnosed before,
Yes. Yes.
the sexual dysfunction from dryness, then please seek medical advice early as possible, and then be on some hormonal therapy, the balanced one. There are a lot of, it's another topic that we can
Yeah.
cover
There's
another day. It's
tons,
a
I'm
long
sure.
topic. Yeah. But then there is no need to suffer. And thankfully, those are small percentages of women, not a lot. The
That's
the
great.
difficulty for me is the misconception. Everyone wants to blame something on something else, right? So a lot of people will come to me, it's menopause, and then I'll go through the questions. Some, yes, typical questions. Can't sleep. I'm sweating to the point my whole bed is wet. Okay, you cannot make that up. This is not
Yeah.
depression. This is not
No.
overwhelmed. Your bed is wet from sweat. That's not. That's bad,
Yeah.
right? So I was absolutely fine, but in the last 12 months, I'm not. I cannot be intimate with my husband or my
Oh.
partner. There
Yes.
was a cut, like a sharp line that changed, right? Then you go like, okay, I can help you. But there are a lot of younger women, not even menopausal. They come to me premenopausal. They have this term. I have low libido. I have no sex drive. I'm overwhelmed. And then I go like, oh, in my head, okay, I'm listening. I've never discounted the patient's symptom. But
Right.
then I dive deep a little. Okay, describe for me a little bit your day to day. She's like, my kids are in 7 teams. I have to drop to soccer, and then I'll have to go this, and then I have to take 3 meals, and then I have to take care of my mom. I'm like, oh, okay, I'm tired already listening. Like, why do
Yes.
you need to put your body through this? Why do you need not? Okay, if my sister is doing that or my friend is doing that, good for them. I'm my daughter is only in one program, and that's the only thing I can do, because that's my human capacity. And I told her, she's like, Mom, my friends are doing this. I'm like, no, I'm not gonna fall into this, my friend or the society. No, that's not me. Pick one thing and be loyal to it and be very committed,
Yeah.
and I'll take you from, and I'll do everything, and I'll make time, and you will be there. And she said, okay, Temis, okay, you got it. I'm a healer, so I have to focus into her mental health, her physical health, and give her some time. Short, like it took me 5 minutes or maybe 10 minutes. She
Yeah.
has 30 minutes with me, so I'm gonna be focusing my energy. Or sometime I go like, okay, come again and see me, come again and see me, right? Like, yes, and I know a lot of physicians will say we don't have time for this. I understand, but you have to. You have to, otherwise you're not. Why is she seeing you, and how can you help her? Some people, if
Yes.
it's those symptoms and you give a prescription, that's wonderful. But some people, and then if you just say, oh, it's not menopause, uh, go see your therapist. How, that's not good either, right? So you
No.
have to make that balanced connection, not too much, not too little, that I understand you, I hear you, but also hear me out. Try to do this, try to do that, and bringing some ideas. Come see me again. Feel good, feel confident, spend some time on you, spend some time on your relationship. They sometimes you
Mm-hmm.
were so focused onto something in life, especially it's not healthy at all where what
Yeah.
we're living now. So I say go maybe do just sit with yourself, put your 5 priorities, drop everything else, and make sure you are part of that priority. Your care, your love to you. Make sure your partner, if you have a partner, is part of that, your
Yeah.
family, and
Yeah.
then give the rest to your kids and balance it. Because anything that goes out of balance, and this is outside of menopause, but it's also menopause.
Yes.
It's women's health. We deal with women's health, and it helps a lot of patients. They go out from tearful and crying into leaving the clinic. They still have all the symptoms, but like they go like it's almost like a light bulb that turned on. I
Yeah.
go, oh wow, okay. And the problem is with women's health, you go to a therapist, but if you don't have enough knowledge with also hormones and this and that,
Mm-hmm.
it's harder for them also to understand how to heal you. And we segregated or separated healthcare so much into the little things that it's not making any sense. So any physician need to sometimes with some patients spend a little more time to break the gap and to
Coordinate.
break exactly
Yeah.
and kind of
Yeah.
address the patient as a whole, not as a segment.
Yep. Yep.
Yeah.
Oh my gosh. Okay. So much of that. I will, because I want you to stay for part two, and we're talking about so many amazing things. So let me ask you one more question
Okay.
before we end this episode and we get ready for the next, because in our next episode we're going to take questions from, I have a
Okay.
list of questions
Um,
from women
awesome.
going through it, living it, and I want you are perfect for this. So, before I let you go on this topic though, specifically, you talked about the stigma, you talk about like all of those kinds of things. So now here we are. We need to see a doctor. How do we how do we broach this topic with our, should it be our primary care physician first, or should it be a GYN? Where do we go?
It's a very easy question, but very difficult question because
Okay.
when we're addressing a doctor, it's not a robot, a system that you go to something and you're expecting exactly the same thing. The
Right.
also doctor has their strengths and weaknesses, right?
Mhm.
So some family doctors are amazing and they hear you. Everyone is amazing and everyone's trying to do their best, but sometimes our best is not the best for the patient, right?
Right.
So I always tell the patient there in the US or in your area, or even if you have to travel somewhere else, you have to go to someone that can help you with your issues and that you connect to. You connect that trust. Because a lot of patients will come to me and say, I went to a doctor and they're like so sad. I can see it because I deal with cancer, different stories. They go
Yeah.
like, the doctor didn't listen to us, or they just said they weren't listening to me and they said this. I'm like, oh, you don't have to see that doctor.
But
Maybe
guess
that
what?
doctor is amazing with other patients. So
Mm-hmm.
connect with your family doctor. Of course, if you have someone, a great family doctor that you have from as long as you had and you feel very comfortable, you have that trust connection. As I say, connecting to the hearts. Go
Yeah.
to your family doctor, and if they're good enough, they'll say, I can help you, or I can send you to someone that can help you. Even a good doctor will not send you just anywhere. They will send you to someone that they know that can help you, right?
Yes.
And then
Yes.
go and see as many that don't be one of those obsessed people that will just go for the sake of going, that it's not the control, it's the connection, right? So but
Yes.
if there's someone that really made you feel bad, no one should feel bad, not
Yeah.
from a doctor, not from anyone. So if it didn't help you with your issue, you kept going 1 time, 2 times, 3 times, and no good reason for not helping you, or
Mm-hmm.
they helped you but you got a horrible feeling. They just did, like they made you either feel little or not important, or that you're not smart enough. No, no, just see someone else. So if
Yeah.
it's a family doctor, go to that. Ask your family doctor in the area to go to which gynecologist. Do your research. We do research in a lot of things. If you wanna buy a T-shirt or a shirt, you go to the mall for 3 hours to buy something.
So true.
When it comes to my health, I just go like just right away. No, do your research. Do your research. See, look at them at the board. Look at them for patients review. Look at their field, like what's their credentialing, and then see them. And if they're good, then stick with them. And they have to help you with their issue. And also, you have to also feel comfortable with them. So, in
Yes.
summary.
Oh my God, no, perfect answer. You're so good at this. I love it. I was gonna say UCR Health is very lucky to have you. I will say that
Oh.
right now because that you are, I can tell you are so
Oh.
first, like you're so passionate. You work with students, so I'm glad you're teaching students to be healers and be this passionate about the profession because that in turn is going to help so many more people. So I appreciate that.
And that's one of the reasons why I work with UCR University California Riverside for our audience is
Yes.
for their mission, because the School of Medicine, the whole School of Medicine, and every employee and every department was built to bring health home, because Riverside was one of the biggest discrepancy between physician to population ratio.
Yep.
So they're started the medical school. They're doing all the programs to try and train more physicians to stay in the area. So once I saw that mission, I'm like, I want to be there. So it's great.
Oh, I love that. I live in Riverside, right next to
Oh,
UCR.
amazing.
So I am
Oh,
a big fan of the school and I
I
am a
love
big
it.
fan of
I
that.
love it.
So fantastic. Okay, so we have a lot more to discuss.
Okay,
We're going to do a question and answer. We have a lot more questions. So we're
wonderful.
going to wrap up this one right now. Thank you so much for your time on
Welcome.
this episode. And everybody join us for the next episode because we are going to dive even deeper with your questions
Of
next.
course.